of this chart are less important than the fact that we draw from a number of different schools and disciplines across the UW. And we have about 850 members across a number of different credentials, institutional roles, and located across the
You froze up on us, Aaron. You know what we might need to do, folks, is if people could come off video until they're about to say something. I think we're eating up all our bandwidth. While Aaron tries to rejoin. Isn't Zoom great? I mean, we've been doing this for years now. We still can't figure out how to work this thing.
It wouldn't be a Zoom meeting if we didn't have technical glitches.
I know.
You know, it feels like home, you know, like come to just reliably unreliable sometimes.
Gosh, we lost Aaron altogether.
I'm back. Sorry, I am in clinic and relying on the Wi-Fi at in the mailing building. So my apologies. Let me see if I can get my screen back. We see slides again?
Yep.
Great. I think I'm going to leave my video off for the time being, just because of bandwidth concerns. So this is our basic programmatic structure. This is where I think I probably froze out. Again, not to get into the weeds of all the details of this, but to show and highlight some of the primary programs of the center. So we have our executive leadership team. We have an arm focused on equity, diversity, and inclusion that's really intended to be integrated throughout the center. And Dr. Rashmi Sharma, who is with us here today, leads that program. We have clinical programs led by Dr. Jim Fausto and Blair Mills as our palliative care director. The palliative care education arm is directed by Dr. Susan Merrill. Our serious illness research arm directed by Ruth Engelberg, and our pediatrics arm directed by Abby Rosenberg, partnering with Dr. Jory Bogetz and Dr. Amy Trowbridge in education and QI. Flip those two names around. And then just because today's journal club highlights some of the work that we are proud of from the center, I thought I'd take a minute to highlight a number of the funders that fund work across the center. Our research funding, we're really proud of our track record. Since 2014, we estimate we've had about $40 million in total direct costs in governmental funding and about $20 million in foundation funding. And we have 2 research training grants that we're proud to help train the next generation of palliative care researchers, a T32 in palliative care research. If anyone on this line is interested in dedicated research training, I'd be happy to talk to you in more detail about that program. And I have the K-12 in implementation science in italics because it's phasing out. We publish a lot each year, and we address a broad and diverse group of issues, some of which I've highlighted here, and one publication of which you're going to learn more about later this morning. So I thought I'd just close. I would invite you all to join us as a member. We've had a revamp to our website in the last year. I think it does a really nice job of showcasing the breadth of work that we do within the center. So I'd invite you to take a few minutes to visit the website. And in particular, if you go to the website, scroll down, there's this box, become a member and receive the latest in news and events, or this QR code should direct you to a form to complete to become a member. I think it would be great if all the new fellows would become a member of the center this year. Becoming a member is free. Really what it does is it connects you to our center mailing list, which we use sparingly, but we like to advertise palliative care related events, programming, and other things that might be of interest over the course of the year. Those were all the slides I was going to share. I'm happy to take questions.
Good job, Aaron. Thank you.
Thank you.
And what we'll do now is I'm going to ask all the fellows to introduce themselves one by one. I'm going to call on you, if you don't mind, and just come on to video so we can see you, so we can all start to identify names with a face. So let's start out with Tiffany. I saw Tiffany on here.
Hi, good morning, everyone. I'm Tiffany. I'm originally from Boston, but I did my residency training in Sacramento, California in family medicine. My interests are loneliness and social isolation in elders, and also exploring death with dignity options in Washington area. Nice to meet you all.
Thanks, Tiffany. Christopher, go ahead.
Yeah, hi, I'm Christopher, one of the geriatric fellows. I'm originally from Southern California, Anaheim, and I did residency in Las Vegas for internal medicine. And my interest is in dementia, specifically like Alzheimer's pathology.
Thank you. Sophia.
Hello, everybody. My name is Sofia Jaramillo. I am from Ecuador. I did medical school in the University of Cuenca. I train in internal medicine in the University of Arizona. I'm happy to be here in the geriatric fellowship. I have particular interests in medical education, frailty, and also care of Latinx population. Nice meeting you all.
Thanks, Sophia. Jesse, how about you?
Good morning, everyone. I'm Jesse Cates. I'm originally from Massachusetts. I went to medical school at the Technion in Israel, then finished my residency back in Massachusetts at Bay State Medical Center. Very excited to be here. And most recently, I've been working on some research on ageism and been very excited about that.
Thank you. Mike.
Good morning, everyone. My name is Mike Bergoli. I am an Army veteran and I had a previous career as a firefighter paramedic. I hail from Hawaii, where I did my medical school, did my residency in Arizona as well. And I'm very happy to be here. My interest lies in the intersection of palliative care and wellness and well-being. I think palliative care does a great job with their patients, family members, but we also take the component of palliating each other and our peers and coworkers. So very interested in that.
Thanks, Mike. Sarah, how about you?
Good morning, everybody. I'm Sarah Cottrell-Cumber. I come from Virginia by way of Mississippi. I am currently a general surgery resident. I just finished my PGY 3-year, and so I'm here to do my fellowship in palliative care and hospice, and then I'll go and complete my general surgery residency and hope to do a trauma surgery fellowship. I'm particularly interested in healthcare disparities, particularly in trauma surgery with communication strategies and healthcare utilization.
Thanks, Sarah. Yasmin, are you with us? Oh, you're on mute.
Success?
Yep.
All right. Hi, I'm Yasmin Curtis. Coming here from Kansas. I'm in the Army, so I'm active duty right now. Did my pediatric residency at Tripler in Hawaii and medical school in Atlanta. Excited to be here. I'm one of the pediatric track fellows. I'd say in terms of interests for me, I have a great interest in kind of healthcare equity and disparities amongst minorities. And then, of course, how we can apply the concepts that we learned to a military active duty independent population.
Excellent. Hannah. You're on mute.
Yep.
There you go.
I'm Hannah. I'm the other pediatric palliative care fellow. I'm originally from New Jersey. I did medical school in San Francisco, and then my pediatric residency here at Seattle Children's and the University of Washington. My interests are around medical education and like how we can take communication skills more into the med ed space, as well as formalize debriefs to help trainees process patient deaths and other severe events.
Fantastic. Thank you. Cliff.
Hi, everybody. I'm Cliff Sung. I'm from the Northeast originally. I did a lot of my training there. I've been here actually for the last 3 years doing a Palm Crit Fellowship. And so been able to meet many of you, but definitely looking forward to learning from everybody more this year. Some of my interests are in underserved populations as well, refugee health, and also developing some more subspecialty palliative care in the world of pulmonary medicine.
Thanks, Cliff. I don't see Dan Bui on our list. Dan, are you on the phone maybe? Nope, we have one more fellow. His name's Dan Bui. I'm sure you'll see him in subsequent gatherings of this type. So welcome, everybody. I'm going to go over the study basics, and then I'm going to kind of interview Rashmi about the study. But again, it's fine to stick things in the chat, and Mike will help us with it. I hear a lot of very similar interests among our new fellows for the study we're going to go over today. So I would encourage you to get in touch with Aaron, Randy, and Rashmi if this study we go over this morning inspires your interest and you think you have similar interests. This is a study of end-of-life healthcare utilization and palliative care use among older adults with limited English proficiency. And Nazli Abedini in our group was the first author of the study, but she conveniently arranged to be on a camping trip today. And another author, Ruth Engelberg, also bugged out on us this morning, and Lois is not with us. So, but we do have Rashmi and Randy with us to talk about the study. This is just a fascinating study. It's not actually in print yet, but you all have perhaps had a chance to look at it attached to the Zoom meeting today. It'll come out soon, and it actually dovetails a bit with an article that just appeared last month that Rashmi was the lead author on in the Journal of American Geriatric Society about challenges and opportunities in research in dementia with COVID-19. So I'm going to ask Rashmi to talk a little bit about that in a minute, and about studies she has going on that you all might want to tag onto her coattails with. But this particular study today tries to parse out limited English proficiency and how it affects healthcare utilization near the end of life. It's a retrospective analysis, or a retrospective cohort study. And the idea was to look at the primary outcomes being healthcare utilization. So any visits to the emergency room, any hospitalization, any intensive care unit utilization, 30-day readmissions, looking back a month and then 6 months before death. And this was a very large study, and it was done right, we're sitting in the middle of where this study was done. This was done in UW Medicine. So in a way, it's kind of a quality, we can look at it and think of it has a flavor of quality improvement. We can look at this study as looking in the mirror and see if we can do a little better, or maybe we're doing a little better already and don't know it yet. But we can talk about that and reflect on that. Rashmi had 1,490 subjects between 2010 and 2018. And this was a medical records review study of decedents. So all these people had died during that period. 1,363 had limited English proficiency, which Rashmi can tell us a little bit more about how that was defined. So about 17,000 who were English proficient, 1,363 who had limited English proficiency. They were about between 80 and 77 years old on average, a little more likely to be female, a substantial excess of people with Asian descent among those with limited English proficiency. With Hispanic ethnicity, they had lower levels of education, were more likely to be on Medicaid, and essentially had higher, people with limited English proficiency had higher utilization of emergency room, of readmission, of hospitalization or in-hospital death, and a number of other things in unadjusted outcomes. A very small fraction had palliative care consultation, 14% with limited English proficiency, 10% with English proficiency. I'm sorry, other way around. 14% of patients with limited English proficiency, 10% of those with English proficiency had palliative care consultation in the last month of life. And a small fraction had advanced care planning documents in the medical record. So what Rashmi found is there's a difference between what happens to people near the end of life right here in Seattle, in UW Medicine, if they have limited English proficiency. So that's a nutshell of the study, and we'll dig into it a little more in detail. But first, I want Rashmi to tell us about herself. Rashmi, tell us about your background. I know you were an internal medicine resident here because I think I was your attending a couple of times. And how did you acquire the skills, the knowledge to do a study like this? How'd you go about it? And what drove your passion? You have to have fire in the belly to do a study like this. This is not easy to do. So you must have a passion about it. So I'd like you to just tell us your background and then tell us a little bit about your passion.
Yeah, thanks so much, Wayne, for the question. And it's super exciting to meet all the new fellows. So I hope you're going to have a fantastic year here. So I'll start with the first part of that question, Wayne, kind of talking a little bit about my background. So I did both medical school and an internal medicine residency here at the University of Washington. And I would say kind of towards the end of residency, I realized both that palliative care was the clinical area that kind of felt like my calling, that those aspects of being able to help communicate with people when they're at this like kind of highest point of distress and to try to help kind of navigate them through a difficult experience was what really resonated a lot with me clinically. So I knew I wanted to do that. And I thought I was interested in research, but I really had very limited background and exposure to doing research. But I was really interested in how people's cultural background, how things like race and ethnicity influenced the way in which people approached communication and made decisions. And I felt like I had seen situations where communication hadn't gone that well. And so I wanted to know, how do we improve communication and support decision-making for these populations? And I felt like there wasn't a ton out there in the literature. And so that kind of fueled my interest in thinking about, could I do research in that area to kind of build up that evidence base? And again, since I really had little research training, part of what I needed to do was figure out if I really liked research and get the skills to kind of do it well. So the route I took to do that was a 3-year general internal medicine fellowship, which I did out at Hopkins, and that included then a master's in health sciences, where I gained kind of, I would say, the quantitative skills, and because I was also interested in kind of qualitative methods, some of those methods as well. And that gave me a chance as a fellow to both get skills, start doing research projects, including a fellowship project that was a focus group study looking at perspectives around end-of-life care among Asian Indians, which was the population, kind of my background. And doing that work was, I think, even more exciting than I thought it would be. So it was like confirmation that research was kind of the thing for me. So then went on to have a faculty position, and then was able to come back to the University of Washington once I had gotten some grant funding to then kind of really pursue this track as a physician scientist. So About 80% of my time is spent on research, and then about 20% is my clinical time on the palliative care consult service. And in terms of that kind of passion piece, Wayne, you're so right in that I have a strong passion in this area, and that I think passion for a topic is really important in order to sustain doing research for so many years. You got to really care about, I think, what you're studying. And so for me, I alluded to this, I'm the child of Indian immigrants. My cultural background has been a huge part of my identity, and something I really value. And so this desire to improve care for populations that are kind of similar to that, hence my focus on immigrant communities, has been a huge driver of the work that I want to do going forward.
Great. That's terrific, Rashmi. Thank you so much for that background. Let's dig into the study. It's hard to imagine how you would do a study like this without it being a retrospective cohort study. Could you tell us a little bit about that? How's it different than a prospective study, and just how you chose to go about it? Makes sense, but
yeah, definitely. So you're that's right. An alternate option would be that we could recruit a cohort and we could follow them forward over time and keep track of what their outcomes are. We would also be able to kind of collect additional data, If we selected a cohort and followed them over time, we could survey them. We could interview them to kind of understand why what is happening is happening. That, of course, takes money and time. And so I think the big challenge with trying to do a prospective cohort study is that that's well suited to, I would say, obtaining a large grant that gives you the money to hire the personnel, to do the actual work of recruiting, following people over time, compensating them, and then recognizing that it's going to be many years before you will actually have collected the data, be able to analyze and kind of draw conclusions. So in lieu of that, there's the option to do a retrospective cohort study where all you need is someone to be able to pull data from the EHR, and then either yourself or others to analyze that data to be able to answer questions. And I think it's a nice way to be able to answer kind of concrete questions. And I think about kind of answering the what questions, So kind of like what is happening, with the idea that there are other strategies to understanding why that may be happening. And I'll talk a little bit about that in a different context. But so, ease of being able to access this data. As you mentioned, we were looking at 2010 to 2018. So we already have that data. So being able to then pull that data to look at this issue of LEP and being able to kind of analyze that. So one can do that with limited resources and pretty quickly.
Still hard.
Yes, you still need to know what you're doing. That's true.
Great. Well, you've shown that older adults with limited English proficiency have higher rates of end-of-life healthcare. And the other thing about a retrospective cohort study, you have to wait till everybody's died. So you can look from death backwards, making it particularly germane to work like this. But can you unpack the limited English proficiency a little bit more? You mentioned culture, literacy challenges, language challenges, but how have you come to think about this? You've got Asians, Hispanics, Russians, all kinds of people among limited English proficiency, yet you still had this finding though. So tell us how you've helped us understand that concept.
Yeah, and so I think there are two pieces to that question. So one is just kind of level setting of what do we mean by LEP, and how do we kind of identify that. And so I'll just mention that there are generally kind of two different approaches to what constitutes limited English proficiency. There's using the census definition, which you'll see in a lot of survey studies where people are asked, how well do you speak English? And any response less than very well is considered limited English proficiency. So that's one way in which people identify that population. And then an alternate way, which is the way we used and is often used in these kind of clinical contexts, is to look at preferred language. So within UW Medicine, when patients are either going in for outpatient or inpatient care, they're asked what their preferred language for receiving medical care is. And so you have to specify a language, including English. And so we looked at everyone who gave a preferred language other than English. And so again, there's no default. If someone says English, that is their preferred language. So anyway, so that's how we thought about LEP for the purposes of who we're kind of talking about, right? So this is patients who said the language they prefer to receive medical care in is some language other than English. So that's kind of who we're talking about. So then when we think about kind of the role of language, it is really complicated because oftentimes people who are speaking, whose preferred language is something other than English, are also bringing, are generally coming from a place other than the US and bringing a set of kind of cultural values and norms and practices. The population that we see with limited English proficiency also generally tends to have kind of lower health literacy. So, you know, as you mentioned, right, we think about how these factors are often related. And so it can be challenging to separate when we think about the decisions that are made or why people make medical decisions that they make, what piece is connected to kind of which aspect of those things. But I would say that I think there are some common elements for patients with LEP in navigating the healthcare system. In other words, being able to or unable to access language services, to have to depend on, say, a family member to translate, recognizing that if there's an interpreter involved, someone is kind of mediating the communication between the clinician and the patient and family, the ways in which all of those things affect healthcare, I think, are common regardless of what language you speak. And so in that way, I think there is something kind of unifying about this LEP piece, that you are navigating a healthcare system that is likely different than kind of what you were used to. So you're trying to like understand how to navigate this system and then facing these additional challenges around language specifically.
Great, thank you. And we see that and feel it, you know, just in care of our patients who are in the hospital. Let's spend a few minutes in the weeds here about the actual data and the statistical analysis. Tell us if there were anything easy about these data acquisition, and of course what was challenging in putting together the database. It's just brilliant how you identified people with limited English proficiency in a way that makes complete sense to us here within UW Medicine. So that's great. But how about getting that electronic health record data? I mean, we changed health records in the middle of this study from a Cerner product to Epic, or we were in the middle of it anyway, kind of a moving target across UW Medicine. And the death certificate data, I mean, how is it hard to do that kind of thing, or how do you go about it?
So I feel like this is a good plug for the Cambia Center in that I think through many projects that Randy and Ruth and many others, including, you know, kind of a diverse group of trainees, have done different types of projects using data from the EHR to look at some patient with serious illness population and some question kind of within that population. So it's nice when you can do a study where others before you have kind of laid that groundwork for who does the abstraction, how does one abstract the variables of interest, and has some experience with these types of data really kind of facilitates the analysis. So I would say one thing that made this project a lot easier was being able to tap into those resources with Jim Sibley, who does the data abstraction, who has done this in many different contexts and knows, you know, what the variable is for palliative care consultation, for example. And then Lois Downey, who has worked with, again, different iterations of these types of data to look at, you know, should we look at ER visits, yes or no, or should we look at continuous number of ER visits? And, you know, how should we think about that? And how should we figure out which covariates we should adjust for in the models? And so being able to have that expertise on a team and kind of plug into that, I think, especially from a fellow's perspective, I would say can really be helpful when you're trying to do work, because there are many decisions that need to be made about which variables you want to look at, how you're going to handle them, and, you know, then thinking about how to interpret the findings you have.
Great. Yeah, and the example of the identifying who had limited English proficiency and who was English proficient is a good example of that. I mean, kind of identifying which, you know, in a way that makes sense and is transparent of how to do that. So that's fantastic. And you're identifying people who were UW medicine patients. I mean, we know our patients here in Seattle, they can go to Virginia Mason or Swedish or Kaiser, et cetera, and do. but you know, by and large, people tend to stick with a system pretty well. So it took some clinical sensibility to decide, to kind of make the cut point of who's a UW medicine patient and who you're not going to look at. And I thought it made complete sense, but can you talk a little bit about how you made those decisions?
Yeah, for sure. And I think this is another place where kind of tapping in to the work that had been done before and kind of how people had thought about that, to think that if you are having, you know, more than one outpatient visit to try to get at this idea of kind of continuity, right, within the system. And then thinking about kind of a hospitalization as being a significant enough kind of clinical encounter to want to look at those patients. And then you're right in terms of how do you decide kind of over what time period, right, people had to receive care, and, you know, 1 year, 2 years, kind of what is the right number. And there I'll again kind of point to really tapping into the way in which this had been thought about in kind of other previous studies. And also want to echo, I saw, you know, Randy made a comment in the chat that I do want to, I think, kind of emphasize this point around as a fellow being able to take on a project where people have already done 10 studies using this data, and so spent many hours thinking about, should it be 24 months or 32 months or 16 months or whatever, kind of simplifies things, because it gets you, it really reduces the amount of things you have to figure out as an individual, and have this group who has kind of really thought about this and has those resources that you can kind of tap into.
Great, fantastic. And the statistical analysis, I mean, you used logistic regression, which probably most of the people on the call have never run a logistic regression program before, but it's kind of a yes, no. Your outcome has to be yes, no. ED visit in that time window of being a UW medicine patient, yes or no. Hospitalization, yes or no. Not length of stay, not, you know, et cetera, et cetera. It's a yes, no outcome. ICU stay, yes, no, etc. And then you had a whole bunch of variables that you had to choose whether they actually confound the result, whether you should include them in adjusting the logistic regression analysis. I imagine that was a pretty long equation. We don't have table 1 for you to look at, everybody, but you'll see lots of variables there that the research team thought hard about. So tell us a little bit about the actual analysis. Walk us through the basics of the covariates. And another thing that changed during the last decade is we went from ICD-9 to ICD-10 diagnostic codes. Was that a problem or just no big deal?
So since we're several years in to that change, which reminds me, I didn't answer your question about EPIC either, which was that this data occurred before that changeover to EPIC. But it was great that you mentioned that, Wayne, because that is an important issue in thinking about how to translate work that has maybe been done before, but wanting to look at like a newer time period does involve having to change some of the data abstraction approaches because the EHR changed. So luckily, I didn't have to deal with any of those issues, but they can be quite a bit of work. So I do think it's important that you highlighted that. So anyways, back to kind of the analysis for this. I think this is a nice place where, as a clinician, being able to kind of draw from your clinical experience in terms of thinking about how to think about some of these issues is really helpful. So an easy answer to part of your question is you can run analyses in multiple ways to try to get a sense of what is the right answer, because one could make a case for, kind of as we did, that any ED visits is reflective of this higher utilization of care, regardless of how many visits that is. It may also reflect the fact that maybe the majority of patients only had one, versus, if you have like a certain number of ER visits, right? Like the more you get or the more you have, there's an important kind of association there. And so for some of the variables, we looked at them in different ways to try to figure out what would make the most sense in terms of our final analysis and being able to run different models to get at that question. I think the thing that we had to we struggled with the most was how to think about race and ethnicity. As you mentioned, if you look at our demographics, I think it's like 65% of our LEP population is Asian, a much smaller percentage being Hispanic. We actually had like 20% who were white, right? That you're alluding to kind of the Russian population, Eastern European, et cetera. So how do you think about race? And so we went kind of back and forth on whether those final models should adjust for race, with the idea being that we're trying to isolate the effect of language, or if the reality is, right, as we think about things like intersectionality, that you can't isolate the language piece from a person's lived experience as they are navigating through the healthcare system, right? It is mixed in with that race and ethnicity part. And so I think how to think about that was something that we spent a lot of time on. And so again, another place where you can run multiple models and try to look at how to tease that out. And then, we were limited by sample size to be able to pull out a specific language or a specific racial and ethnic group and kind of look more at what was going on for that group. So that's one of the challenges, right, when you're doing retrospective analysis, is you're kind of dependent on the numbers that exist. And so you can only answer certain questions.
Great, thanks, Rashmi. That's fantastic. And that's the fun when you're a newish scientist, to have a database this beautiful and to work with it and to slice it and dice it and look at it lots of different ways is a great learning experience. Even if you've been at it for quite a while, looking at it multiple different ways, it's fun and gives you more confidence in what you're actually looking at and gives you ideas about looking at it different ways. Secondly, you roll around to the right way to look at it, especially with a bunch of really good helpers and thinkers. So that's the part of the fun of the science, working with people like Randy and Aaron and others that you've mentioned. Well, you had an enormous sample size. I mean, what you mentioned about the subgroups is important, but you had, 18,000 plus people to look at. And some of the differences that you found, I mean, maybe weren't clinically important, or maybe they were. So you had to decide about that, because with that big sample size, you can find some statistically significant differences. So like with age and, gender and stuff, do you think those were important differences, or they were just there and you adjusted for them anyway? But tell us a little bit about what stuck out to you as what was clinically significant, or maybe not.
Yeah, and I'll say with the demographics, I think that mirrors the kind of population we're looking at. So when you look at, and so we were looking at older adults, so that simplified some questions around that. And I would say, as we think about kind of the race and ethnicity piece of it, that we see an older population among the Asian American populations, not surprising again, both thinking about the Seattle population and the fact that we're focusing on older adults, that we would have such a large Asian American population and a smaller Hispanic population, which, as we think about the Hispanic population served by UW Medicine, tends to have a younger demographic. So just to kind of give that context to people as they're trying to kind of make sense of our population. I think this issue around clinical significance is an important one. And I think a point I want to bring up here is, we're looking at utilization of care. And so to what extent that is kind of bad, right? To what extent that's a marker of quality of care, I think is an important thing to think about. And so, these data, as with other studies that have looked at other groups of minoritized populations, find higher utilization of care, higher intensity of care. We look at things, right, like ICU admissions, et cetera. And so I think the clinical question is that a bad thing? What if that just is in line with what people's values and goals are, right? What if they want to die in the hospital and thus a higher proportion die in the hospital? And so I think, some aspects of these data, like 30-day readmissions, we can look at as that is meant to be a marker of quality of care. So having increased 30-day readmissions is considered a bad thing, or a marker of kind of poor quality. But in and of itself, in hospital death, that's the place where I think future studies, which I'll make a plug for mine before I forget towards the end, to answer the question of, is this what people want? And that's why there is this higher utilization of care. Or are they having these multiple emergency room visits because they're not able to get their needs met through, let's say, the primary care setting, the home setting, being able to access, say, hospice services because of kind of the cultural and language barriers. And so, to what extent some of this utilization of care is avoidable or not is something that we weren't able to kind of tease out just using the kind of the methods that we use to kind of pull from the EHR, because that piece of preferences, values, and goals was not a part of kind of what we were looking at. And there are other strategies to then look at the content of goals of care discussions, for example, that could kind of fill in, I think, that important piece as to the clinical significance. So the final point I'll say about that is like, look at palliative care consultation. I'm not sure we know what is the right percentage of palliative care consultation, right? I think we can say not every single individual maybe needs a palliative care consultation, but like maybe a fair amount too, or like many. These numbers seem low, so I think we can say that 10% sounds kind of low. But as to what are we aiming for, I think is kind of less clear.
Right. Great. Thanks, Rashmi. Mike, you want to jump in with some
Sure.
things that have been on the chat? And while you're doing that, Diane, can you try to bring up table 3 for us to look at?
So one of the points here that was brought up by Dr. Curtis, since we're on the data analysis section, is the problem of multiple comparisons and how in the hypothesis testing phase, it is not okay to analyze the data multiple ways and pick the results you like best. So I was wondering if Dr. Sharma, you might be able to address that.
Yes, so I think you need to be thinking upfront about kind of how it makes sense to answer your question. And I think, what Randy's getting at here is that you don't want to take an approach of, I will run something multiple ways until I find a significant result and thus present my significant result. As opposed to, I will think ahead of time of like, what is the question and how we should answer that question, and then see whether those results are significant. Having said that, I think that sometimes there are places where the answer is not completely clear as to, like, one could make a strong case for presenting, for analyzing something in 2 different ways. And I think, there can be an opportunity to kind of, as a almost like exploratory exercise, trying to kind of see how the data looks to get a sense. But yes, I think the idea of like doing enough analyses to get a significant result can really diminish the rigor of the science.
And then I know we're going to be getting into tables 2 and 3 soon, but since we're getting into that subject, there was a question here by Barb Hansen regarding whether or not hospice use was tracked in LEP patients, and if this was possibly a confounding factor. So I was wondering if maybe you could address that as well.
Yeah, great question, Barb. I think it's an important question. It would be nice to be able to have these data. It has been hard to be able to have an accurate way of abstracting hospice referral from the EHR because of the way in which patients are referred to hospice. So, many times people in the hospital setting might talk with the team, the social worker, about hospice, and then some component of that actual referral process is going to take place outside of the hospital, whether or not they're kind of meeting with the hospice liaison, how that's documented. So for those reasons, we still don't have a good way of identifying which patients are referred to hospice from the EHR to be able to measure that in a reliable way. But that's such an important variable. And a great question.
And there is another question in the chat, but I think we're going to get to that question later on in the interview. So I'm going to hold off on that.
Okay, well, we only got about 5 or 6 minutes left, Mike, so don't hesitate to jump in there. Well, what should we make of this low amount of palliative care consults and advanced directives, Rashmi? It was a decade ago, and our new fellows should know that, that the palliative medicine fellowship began at the beginning of this study in 2009, 2010, around in there. But as Randy commonly reminds us, the floor of palliative care performance across a medical system is a moving target, tends to get better over long periods of time. So it may be that and Elizabeth Phelan, I think, put this in the chat too. It may be that if we did this study this decade, it'd be different, or maybe not, I don't know. But what do you think about the moving target piece?
Yeah, so maybe here I'll do my plug for my current work, because in one of the studies, we're going to be looking at data through 2021. So hopefully at least we can sort of answer that question a little bit. Okay, so the plug is that currently I have 2 studies that are going on. One of them focuses on Latinx, Chinese, and Vietnamese older adults with dementia and understanding barriers to palliative care. So I bring this up here because that study is designed to try to unpack what is going on with these populations to understand how we can improve care for those populations. The first aim will be looking at EHR data up through 2021 to look at how utilization of care, including palliative care consultation, may have changed over that time. And then we'll also be looking at documentation of goals of care discussions, which was not included in this paper, but is another area that we're interested in, right? So being able to look at kind of rates of goals of care documentation, and also, you know, possibly being able to look at content of those discussions. And then that study has kind of a heavy qualitative part where we'll be doing interviews to try and understand from the perspective of patients, family members, clinicians, interpreters, et cetera, multi-level targets to kind of improve palliative care. So again, that focuses on Latinx, Chinese, and Vietnamese, older adults with dementia and LEP. And then I have another study that focuses on Latinx, Vietnamese, and Somali patients with advanced cancer, and similarly looking at barriers to palliative care there. So the plug is that for fellows who are interested in those populations, those topics, especially thinking about the role of palliative care in the context of dementia, there are opportunities to get involved with projects, and I'm super happy to talk with anyone who might be interested. So that was my plug, and to say that we will generate newer data to look and see if that number has changed over time.
Excellent. And Diane's pulled up table 3 for us. You see that the unadjusted analysis and everything was highly significant, but even with the adjusted for a lot of covariates, which really harms your ability to find statistically significant differences, there were still these several items that were still highly statistically significant. And those were the only ones alluded to by Nosley and Rashmi in the abstract. So terrific work. Well, in our last few minutes, actually, Diane, if you can pull up the forest plot, which is the figure, that'd be great. But Rashmi, walk us through this forest plot and then tell us a couple of nuggets, since this is kind of looking at ourselves here at UW Medicine and our performance last decade compared to 2022. What should we be doing to improve ourselves going forward? But first, tell us about this forest plot. It's always nice because pictures are usually worth 1,000 words.
Yeah, Nosley did such a nice job with these forest plots. They really came out great. And as you said, I think it's a nice kind of way to visually see these adjusted odds ratios. So these are using the odds ratios from that model that did adjust for other covariates, including things like race and ethnicity. And you can see those those outcomes with the larger numbers and the lines that are further out, further away from that central line are statistically significant. So you know, it's a nice visual way to look and say, oh, 30-day readmissions really stands out, as well as ED visits as an area where patients with limited English proficiency have a significantly higher odds of having those things. And, you know, when you look down at the bottom one there, so the top plot there is looking at the last month of life, the blue, the orange is looking at the last 6 months of life, And you see the pattern is similar, right? So there's nothing really different that's happening in that last month of life versus the last 6 months of life. And then in the green there, you're seeing documentation of advanced care planning, as well as in-hospital death. And so again, there you see those being kind of statistically significantly different, and not surprising, right? Like we have tons of other papers showing that ACP documentation is lower in all other kind of racial and ethnic minority groups. And I think it's not a surprise that in a group with limited English proficiency, that they would be less likely to have completed those documents. So not a surprise. I think as we look forward, I think the takeaways I would want people to have is that there is something unique about having limited English proficiency that in and of itself kind of sets people up to have these higher levels of utilization of care. I think one, that means we are seeing these patients in the hospital setting. And so thus, as we think about opportunities to have conversations about goals of care, to introduce palliative care, I think the inpatient setting is an important one for this population because we see that's where folks are accessing care. And that we really do need to think about how to better serve these populations when we think about, like, how do you talk about these things in a way that's sensitive to both the cultural and the language piece, and language access, interpreter services.
Great. Thanks a million, Rashmi. We're a couple of minutes over time. Mike,
Oh, goodness,
thanks for your
sorry.
help. There's some good stuff in the chat if people just want to read it. But in any case, this has been terrific, and I appreciate everyone's attendance this morning. Thanks a lot, and we'll see you all around. Bye-bye now.
Thank you.